everybody. I am pleased to give this web conference on Kogan syndromes for the FAI²R today on Kogan syndrome. So the definition of the Kogan syndrome. The Kogan syndrome was described by the ophthalmologist David Cogan in 1945. He reported 4 observations of non-syphilitic interstitial keratitis associated with vestibulo-auditory dysfunction like Meniere's disease. And in 1980, Heinz extended the definition, the original definition of Goggans by the atypical Kogan syndrome because there were visual manifestations associated or other than the interstitial keratitis, or there were vestibulo-auditory manifestations other than Meniere's syndrome, or because the delay between the eye and the vestibulo-auditory symptoms were more than 2 years. As you will see later, in Kogan syndrome there are many systemic manifestations, and especially in the atypical Kogan syndromes. And in the Chabelil revised nomenclature, the Kogan syndrome is classified as a vasculitis of variable vessel, like Behçet's disease. In terms of epidemiology, Kogan syndrome is a very uncommon vasculitis, and as you see, about 300 reported observations have been published in the literature associating both typical and atypical Kogan syndromes. These syndromes interest usually young adults between 20 and 30 years in approximately 50% of the cases, but Kogan syndrome can occur in infants and also in patients older than 60 years. The sex ratio is about 1. There are no familial predisposition, and Kogan syndromes can occur in all ethnicities. The pathophysiology of the Kogan syndromes remains totally unknown. A trigger role of an infection of ear, nose, and throat has been debated, but usually the infectious survey is non-contributive, and there is no efficacy of various trials of antibiotics in these syndromes. Probably the most convincing evidence comes from autoimmunity, because there are reports of internal ear autoantibodies in Kogan syndromes, and the team of Lunardi in Italy has described Kogan peptide, that is a Kogan peptide that has some homology with SSA, laminin and connexin 26 that are highly expressed in the inner ear, and also a tyrosine phosphatase that is also highly expressed in the inner ear. And also some patients in Kogan syndromes are also have also some antibodies against HSP70s. Some antibodies against corneal tissue have been reported in Kogan syndrome also. What about the clinical features of Kogan syndromes? The onset in 25% of the patients is marked by an ENT infection. The eye manifestation or vestibulo-auditory manifestation are isolated in 80% of the cases. In 20% of the cases, there are at the same times both the eye and the vestibulo-auditory manifestations. And the mean delay usually between the two types of manifestation, the eye and the vestibulo-auditory, is usually 3 months. Concerning the eye manifestations, the patient may experience some pain, some eye redness and photophobia, some decreased visual acuity, but this is rare. And you should know that the interstitial keratitis, which is the hallmark manifestation of Kogan syndrome, may be asymptomatic and should be searched by a systematic eye manifestation in some patients. The eye involvement is usually bilateral, and the hallmark is the interstitial keratitis, which is seen in the slit lamp examination as a deep granular corneal infiltrate, and secondarily you may have some peripheral corneal opacification and also some neovascularization that could occur late in the disease course. You should know that interstitial keratitis is non-specific of Kogan syndromes and may occur in various infections such as syphilis, but also tuberculosis, Lyme, or also HSV infection. This slide shows you some example of a non-syphilitic interstitial keratitis. On the upper left, you have the deep granular corneal infiltrate, and on the upper right, you have the peripheral corneal opacification that may occur late in the course of the disease, and also on the left bottom, you have some neovascularization that can occur as a sequela of the disease. Probably this may represent some inflamed blood vessels, some small blood vessels that invade the normally avascular corneal stroma. This is another example of the peripheral corneal opacification that you may observe in the disease course of Kogan syndrome. And as I said, in atypical Kogan syndrome, you may have some other eye manifestation in association or instead of the interstitial keratitis, and it could be conjunctivitis, episcleritis, scleritis, uveitis, or retinitis. Usually the visual prognosis is excellent, and blindness is observed in less than 10% of the patient. Regarding the vestibular auditory manifestations of Kogan syndrome, typically you will have some mania-like attacks with vertigo, ataxia, nausea and vomiting, hearing loss and tinnitus, and the course of the vertigo is fluctuant over weeks, and then it may disappear, and you will have the hearing loss, and typically the hearing loss is rapidly progressive, profound, and bilateral, and usually irreversible. This is a bilateral perception deafness that is observed in more or approximately 50% of the patients. The audiometry will demonstrate sensory neural hearing loss, and the imaging, both CT and MRI of the inner ear, will show normal results or evidence of labyrinthitis. In Kogan syndrome, you may have some systemic manifestations in 30 to 40% of the patients, and the systemic manifestation may be more common in atypical Kogan syndrome. There could be some general manifestation associating fatigue and fever, for example, but the most common systemic manifestation are cardiovascular and may associate aortitis, usually of the ascending aorta, associated eventually with aortic valve insufficiency because of dilation of the aortitis in 10% of the patients. It could be some large vessel vasculitis, and less commonly some median or small vessel vasculitis. Rarely you will observe some myocardial infarction due to coronary vasculitis, some myocarditis, or some pericarditis. Other manifestations have been reported, and there are plenty, and could be neurological manifestation, arthralgia or arthritis, digestive manifestation, skin rash have been reported in Kogan syndrome. This is an example of aortitis, and you see in the upper part of the slide a parietal thickening of the aorta, and on the TEP scanner on the lower part of the slide you show the hypermetabolism and the slight dilation of the ascending aortic portion of the aorta. Biology, imaging, and pathology, and you have in 35% of the patients, especially at the onset of the disease, some elevated CRP or ESR. The immunology workup is usually negative. There is no ANA, no ENCA, and no testing positive for immunology. The microbiology survey is usually negative, and the syphilis serology should be negative. In terms of imaging of the inner ear, CT and MRI are normal or may show some labyrinthitis. The TEP scanner could be useful for imaging large vessel vasculitis that could occur in 10% of the patients with Kogan syndromes. Echocardiography useful to look for the aortic valve and aortic and the aorta. In terms of pathology, there is non-specific vasculitis, sometimes mimicking giant cell arteritis or Takayasu arteritis in the large vessel, and the temporal bone biopsy, which is sometimes available at the time of a cochlear implantation, usually shows some fibrous tissue and extensive new bone formation in the inner ear. And the sampling is late, of course, and there is no evidence usually of vasculitis in the inner ear. In terms of the diagnosis, it is usually relatively easy in typical Kogan syndromes with the association of the keratitis, interstitial keratitis, and the vestibular auditory manifestations. But it may be very difficult in atypical Kogan syndrome, and you may discuss in the differential Meniere's disease, Vod-Koyanashi-Arada, Susak syndrome, for example, or many systemic disorders that may associate both eye and vestibular auditory manifestation. And this could include GPA, relapsing polychondritis, lupus, sarcoidosis, Behçet's disease, etc. Don't forget the infectious disease also that could associate eye and vestibular auditory manifestation. And in a recent case record of the New England Journal of Medicine, this man presented both eye manifestation with a keratitis uveitis and vestibular auditory manifestation and sensory neural hearing and vestibulopathy. He had a skin rash, he had some weight loss, fatigue, he had eye SED rate, and finally the diagnosis was syphilis. The disease course of the Kogan syndrome, most often the patient will experience both ocular and or vestibular auditory flares. The deafness is the main outcome of Kogan syndromes in approximately 50% of the patients. Possible long-term large vasculitis with aortitis signify that you should monitor the patient on a long-term basis for the aorta. Finally, in terms of treatment, this is completely empirical because there are no therapeutic trials in this syndrome because it is very uncommon, very rare, and the main treatment is corticosteroids. Usually you can manage the eye manifestation only with topical ocular corticosteroids, but systemic therapy usually very compulsory for systemic manifestation or the vestibular auditory involvement. It is prednisone at high dose, 1 milligram per kilo per day, eventually associated with IV bolus of methylprednisolone, but sometimes or usually at a modest or non-efficacy on the auditory deficit. Some specialists may use intratympanic corticosteroids. In more than 50% of the patients, you should use a second-line treatment in association to corticosteroids. It could be a synthetic DMARDs such as methotrexate, azathioprine, mycophenolate mofetyl leflunomide, cyclophosphamide, or a biotherapy. And most have been used are the anti-TNF-alpha infliximab or etanercept, and a few case reports have reported some success with rituximab or tocilizumab. And I want to insist on the cochlear implantation, which is very, very useful and has modified the prognosis of the patient with deafness, which is the main manifestation of this disorder. And on this slide, you have the recommendation that could be made for this syndrome. When you have vestibulatory manifestation or systemic manifestation or severe eye manifestation, you should use a general corticosteroids at high dose, as you can see on the slide, in association with an anti-TNF-alpha or a DMARD, such as methotrexate, which probably is credited of the more efficacy in Kogan syndromes, eventually associated with intratympanic corticosteroid injection. And on the top left, you can see with the eye manifestation, sometimes are easily or maybe controlled by the eye drop or corticosteroids, but a lower dose. And when you get a vestibulatory auditory response with corticosteroids and an anti-TNF-alpha or a DMARD, then the treatment duration is not defined, and you should decrease or taper the corticosteroids to obtain the minimal dose efficacy for those patients. And when you don't have a vestibular response, then you should try another treatment, a second-line treatment, either with cyclophosphamide or try another biotherapy, for example, with tocilizumab or rituximab. And don't forget the cochlear implant, not too late before ossification of the cochlea. Finally, in conclusion, I could say that Kogan syndrome is a very uncommon systemic vasculitis, despite its extended definition to atypical Kogan syndrome by Hines in 1980. It is classified as a variable vessel vasculitis in the Chapelil nomenclature. Its pathophysiology remains totally unknown, although autoimmunity is probable in this syndrome. The most serious manifestation of Kogan syndrome is the auditory deficit, and many patients experience irreversible bilateral deafness. Treatment of Kogan syndrome should combine corticosteroids and a second agent that could be a DMARDs or an anti-TNF-alpha, despite the absence of data obtained from therapeutic trial. Cochlear implantation has been a major advance for these severely disabled patients. Thank you for your attention.